think we'll get started. So it's my pleasure to introduce Dr. Sherry Grace for today's round. Sherry is a full professor in the Faculty of Health Sciences at York University, and she's a senior scientist within the cardiac rehab team here at Toronto Rehab. Sherry's given the title of her talk. Her research centers on global cardiovascular rehab, access and delivery, as well as cardiac psychology. She's a prolific author. She's published over 200 peer-reviewed papers, and she's earned a Canadian Association of Cardiovascular Prevention and Rehabilitation Leadership Award. So, Sherry, thank you.
So it's a real pleasure to be here and share with you some of our recent data. So this is hot off the presses. I presented this in India just a couple of weeks ago for the first time. And so I'm delighted to be sharing it here with you today, and we'll soon be getting it submitted to a journal. So cardiovascular disease is the leading cause of death around the world. Here you can see the leading causes are quite a few non-communicable diseases. We can treat cardiovascular disease acutely quite well. So if you come in to UHN with a heart attack, chances are that we can restore blood flow and get you on your way. But this doesn't mean that you're cured. So many of your heart, your vessels, your vasculature is still diseased. And so we need to make sure we minimize the chances of patients having a repeat heart event. So the United Nations has had a high-level meeting and is having another one soon on non-communicable diseases, given this gross burden. And here you can see the global action plan that they tasked the World Health Organization to develop. And as you can see, one of the key recommendations in this global action plan is to ensure that there is quality rehab integrated into the continuum of care. And if you look specifically at the cardiovascular disease recommendations for the specific NCD of CVD, in the bottom here you can see that cardiac rehab specifically is recommended as a strategy to address and control the burden of cardiovascular disease globally. So what is cardiac rehab? So we have our program over at Rumsey, and also we have one at the Western. And these are chronic disease management models. So it's an established model of care with multiple components that are internationally agreed upon. So this includes an initial assessment of risk factors and goal setting, structured exercise training, nutrition counseling, medical risk factor management, patient education, and the like. As you can imagine then, it's often delivered by a multidisciplinary team so that there's expertise in all of these various elements of secondary prevention. The benefits of cardiac rehab are very well established. So the most rigorous methods are applied by the Cochrane collaboration, who really synthesizes a lot of evidence for health care decision making. And their latest review on the benefits of cardiac rehab showed significant reductions in the order of 20 to 25% in cardiovascular mortality in those participating in cardiac rehab compared to usual care. They also showed 20% lower rehospitalization and improved quality of life. So based on the level of evidence and the benefits, many indications for our heart disease indications, their clinical practice guidelines recommend referral to rehab. So here you can see a list of the various guidelines from the States, but this holds true in Canada and Europe and around the world, that rehab is a level 1 class A recommendation, so it means it's useful, it's effective, and that we should do it. Unfortunately, however, cardiac rehab is grossly underused. Here's a map showing a review we did a few years ago where we just looked into the literature to see where we could identify that cardiac rehab was actually available in a given country. Not how much was available, but just did it even exist? And you can see that the dots on this map here, the countries that did have rehab, and this is only 40% of countries in the world we can have it. And this is quite stark considering that CVD is the leading cause of death. So my program of research is really centered on what happens to patients once they leave acute care. So following them to make sure that we can, again, reduce this risk of them having another event and optimizing their outcomes. Most of my research has stemmed on the flow, particularly from the inpatient setting to cardiac rehab. And this is really important because if we don't get patients to rehab, they're not going to achieve these benefits of 20% lower death and disability. My research today that I'm going to talk to you a little bit looks here around kind of availability and the models and how it's delivered around the world. So how is it delivered? We have, colleagues did a review recently of cardiac rehab guidelines around the world. They identified 18 different countries that have cardiac rehab guidelines. And what they found was quite a bit of variation in terms of what's recommended in these guidelines for cardiac rehab. Similarly, we followed up recently and did a review of studies where cardiac rehab programs in a whole country or a whole region of the world were surveyed in terms of what they look like, their components, and who delivers it. And we were able to identify 28 such studies. And in these studies, 50 countries were kind of described. So if we think that 40% of the countries in the world have rehab, well, currently we think about 113 have rehab of 200 countries in the world. We only know about how it's delivered in 50 of these countries, which is less than half. So clearly there's a real gap in knowledge about kind of what care is being delivered in these countries. So I'm the chair of the International Council of Cardiovascular Prevention and Rehabilitation, and we are a conglomerate of named board members from national or regional cardiac rehab or cardiac societies from around the world. So we have representation on our council from 29 various, as you can see on the slide, medical associations, and we're official members of the World Heart Federation. And our aim is to ensure that cardiac rehab is available everywhere for all patients who need it, and that what kind of care is delivered is quality care. We recently developed guidelines on how to deliver cardiac rehab in low resource settings. So as I showed you, we only have guidelines in about 18 countries. Those are mostly, 16 of those are high income countries. Most of the burden and death of heart disease is in low and middle income countries. And so we set out to develop guidelines where we specify how to deliver each of the core components in a really affordable, feasible way in a low resource setting. And these are kind of, you can think of them as minimum standards of what we would want to see in a cardiac rehab program around the world. And so when we take a look at what is being delivered, we can juxtapose against these minimum standards to see if these benchmarks are being met. So the objectives of this study that I'm happy to share with you today, we went out as ICCPR and we set out to, in a primary way, determine in what countries currently rehab is delivered. The previous review I showed you, as I mentioned, we just reviewed the literature. So this time we went out and actually asked and searched in every single country whether they had rehab. And then we took a look at kind of who funds them and how much capacity they have to deliver, so how many spots they have. And then we looked at the nature of the programs and took a look at whether, again, they meet these minimum standards. So things like what types of patients served, does that match the guidelines? What kind of healthcare providers do they have in terms of delivering these core components? And indeed, what kind of core components they offer. I'm going to take a look at these by WHO region or World Health Organization region so we can get a sense of how things differ around the world. So this was a quantitative study, observational, cross-sectional. And what we did was we first compiled a list of every country in the world, of which there are just over 200. And then we went to our literature review and other literature reviews to identify which of these countries have rehab. And then we had a list of countries left that we weren't sure whether or not they had rehab. So we contacted cardiac rehab societies if they had one available in that country. We contacted cardiac societies if there was no cardiac rehab society. We contacted champions in the field through our key contacts with the ICCPR. And we also went to these international associations such as the International Society of Physical Medicine and Rehab, the European Society of Cardiology, the World Heart Federation. And so we made sure that we could ascertain in each country whether there was, yes or no, any cardiac rehab. In the end, we determined that of 203 countries, 111 of them offer rehab. So this is just 54.7%, up from what we thought before of 40% from our lit review. So then what we did was, I'm going to show you a little bit about, more which countries those are and the density of rehab in those countries. But what we then went on to do was to try and identify every single program in all 111 of those countries. And so we engaged a champion or the society from each of those countries and offered them authorship in return for collaboration with us to identify every single program. And so we said we want to find programs that offer post-acute care, so not inpatient rehab, but outpatient, and that the programs had to offer at least initial assessment, structured exercise, and another strategy to control risk factors. So they either gave us a list of emails of programs, or they sent out our survey link to their contacts. And what we did was administer a survey through REDCap, and we emailed that to kind of optimize response rate through a structured procedure. So what was the survey that we administered? So in some previous work to this study, which I'm sharing with you, we had reached out to all the authors that we identified of these studies that had done national surveys of rehab programs. And many of them, most of them, shared with us their surveys in return for collaboration. And so what we did was integrate all the items and standardize them into kind of a reference English survey. And then we pilot tested that in Canada and in the Arab world. So that included countries that were high, middle, and low income. And so we could ensure that the questions were going to resonate and be valid in various settings around the world. The survey itself contains questions about who funds rehab, accepted diagnoses or indications, patients served every year, the composition of their staff, the dose, so how much rehab patients would get, how frequently do they come on site, for how long is their program, the core components delivered, whether they offer alternative models. So our programs here, we offer home-based services, so patients who can't come in, we give them the same elements, but we support them on the phone or over email. And it's shown that these programs have equivalent benefits to supervised programs. And then we also asked the programs about barriers to delivery to more patients. So this was the items in the survey. The results I'm going to share with you are primarily descriptive, but I'd also like to say that we did take into account the fact that there's a lot of programs that responded within countries, and so they obviously cluster together. And so we used generalized estimating equations to take into account that variability. So when we looked at differences by WHO region, we used multivariate approaches. So first of all, let's take a look at the results, the response rate. So of these 111 countries that have cardiac rehab, we were able to collect data in 94. So that's a very high response, so 84.7% of the countries with rehab. Within those countries, we were able to get about 10, on average 10 surveys per country. And overall, we had over 1,000 surveys, and this was on average a 32% response rate. I do show you, however, that there was variability in our response rate. So the green country showing green here, we had a very high acceptable response rate, about 70%. But in the country showing yellow, we had a moderate response rate, and in the light blue, it was quite low. So we need to be cautious about generalizing findings from these places. I would also like to point out that in the United States and any country that had more than 250 programs, we surveyed only a random subsample and not every single program in the sample. So 1,082 doesn't represent 1/3 of the programs in the world. It represents 1/3 of programs in the world, plus there's another 1,500 or so in the United States that aren't surveyed. But we do plan to survey them in the near future. Okay, so let's take a look at our results. I'm going to show you first a little bit about the nature of the programs, and then I'll talk to you in a little bit more detail about the availability, because I think it ties in nicely to the barriers and how we can address them, and a discussion of that at the end of the talk. So this first shows us who pays for cardiac rehabilitation. And this really varied by WHO region. I'll orient you to each of these slides to start. At the top, you'll see the colored for the bars, and these are each WHO region of the world. So Africa, Americas, which is us. The EMR is Eastern Mediterranean region. Europe, SEA is Southeast Asia, Western Pacific, and then global. So the far right bar in each of the sets of bars is the average for all surveys globally. You can also see at the top of the slide the number of surveys per region. And at the bottom you can see the number that responded with that option. And then in the very bottom you see the p-value. And so here you can see obviously the bars do vary, but with the generalized estimating equation we put the p-value in the bottom so you can see whether there is significant variation globally or not. So what the results show us here is that primarily programs over 50% are funded by some kind of public source. So that could be the hospital or government. The second most frequent is a hybrid source of funding. So that would be some kind of private funding and some kind of public funding. And then finally was private funding alone. It was the least common. That private funding would be insurance companies or often patients. Patients paying out of pocket. And unfortunately, in 72% of the countries, patients paid out of pocket some or all of the cost to attend. When they did attend, if you look at kind of purchasing power parity, so 2016 US dollars, it would cost patients on average $600 out of pocket to attend a program across the globe, which is quite exorbitant for patients in low and middle income countries, as you would imagine. Next we look at staff composition. So here in the top right, you can see that on average, programs had 5 staff overall, and this did vary somewhat by...
Code any position staff, all clear. Code any position staff, all clear. Code any position staff, all clear.
So this did vary significantly, this did not vary significantly by region, there's no star there. But I guess the nature of the staff within the countries did vary. Then the 5 most frequent are shown here. So the most frequent was a physiotherapist or an exercise professional. The second most frequent was some form of nurse. Third was some form of MD. Fourth was some form of nutrition professional. And fifth was a mental health care provider, so psychiatrist, psychologist, or social worker. Again, as I mentioned, there's some variation by WHO region. And I also show here at the far right community healthcare workers. So in our consensus statement, we've suggested that community healthcare workers be integrated into programs. And we have an algorithm of how they can, with their level of expertise, deliver each of the core components in a basic way. And it's unfortunate that most programs are not exploiting this as an option. Next, let's take a look at accepted diagnoses. So I had shown you earlier the clinical practice guidelines for the cardiac indications that where rehab referral is recommended. So as you can see, almost 100% of programs do accept patients with myocardial infarction or acute coronary syndrome, so a heart attack. Also, most programs take revascularization patients, so be it percutaneous coronary intervention or bypass surgery. Some of the variation you see there, so for example, it's lower in Africa, is likely due to the fact that there are less procedures done there. So this is more of a function of the nature of the patients that they get in rather than whether they are practicing in accordance with guidelines. Heart failure is next most frequent, and that's interesting because most recently it's become an accepted indication. There's a major trial that came out, and guidelines now recommend it as a class 1 level A. It used to be level B evidence, and so it's nice to see that upwards of 90% of countries are accepting these in regions. At the far right, I show some other indications out of interest. There were others, but I selected these. Congenital heart disease in high-income countries now can be quite well managed in the pediatric setting, and we're now getting adults who've survived in our programs. In the developing world, there are many pediatric cardiac rehab programs. So you can see again in Africa in some places that's quite common. The next is rheumatic heart disease. Again, this is quite common in low and middle income countries. And finally, we see non-cardiac indications. So about 60% of programs took primary prevention patients, 50% took diabetes or peripheral vascular disease patients, 40% took stroke patients. So this is very much in line with the NCD focus, given there's common risk factors across these groups. And it makes you wonder about, though, the funding. And so does this bring more funding in for cardiac patients, or does this take up spots for cardiac patients? So I think that's an interesting area of future study. Here's information on dose. So frequency of sessions per week is found on the left. On average globally, we see about 2.5 times a week that patients would come on site. On the far right, you see the duration in weeks. So the average program is about 11.5 weeks. So this puts patients at about 25 to 30 sessions on average. We don't have good evidence around minimum dose, but some of our work and our reviews suggest 36 is quite good, but 12 can be minimum as well. So I think we're kind of in that range, but clearly there's quite a bit of variation in the duration of programs around the world. Lastly is the core components delivered. Out of 10 that are really key and again internationally agreed upon, we saw an average of 7.5 being delivered. This is very high and very, very encouraging to see. The most common being patient education at almost 95%, initial assessment over 90%, management of medical risk factors 90%. Exercise training looks a little low here, and I think that's a function of how we measured it. So we had items that could have been conflated. We had, for example, exercise prescription, exercise training, physical activity counseling, and so I think that might have impacted that result there, and I would imagine we need to look a little bit more closely at that. And particularly considering our inclusion criteria was that programs offered structured exercise training. Not quite as frequent was dietary counseling. Unfortunately, less than 70% had a stress management, which is a core component. About 1 in 5 cardiac rehab patients has depression, and so this is quite low. And then finally, really low was occupational therapy and vocational counseling. Again, discouraging because patients in lower resource settings would financially have to return to work. And so it would be important to consider how to do that in a safe way, and how to perhaps modify the work environment to make it safe and feasible for patients to return. So the last part of my talk, I'd like to speak to this issue around kind of availability, volumes. As I've alluded, it's quite low. So we need to talk about barriers and what we might be able to do about that. So here is a bit of a busy slide. So on this slide, I show you the countries where there is no active program. So the dots, so as you can see in Africa, there are many dots. So those countries have absolutely no rehab. So it doesn't talk about how much rehab is in the country, but this is just showing you, do they have any at all? Does it exist? So as we mentioned, there were 111 countries that had it of the 203, so the dots are showing you those that don't have rehab. And then, for interest's sake, I've just juxtaposed this against the prevalence of ischemic heart disease. I wish that we had the incidence of cardiovascular disease globally, so then we could really take a look at the mismatch between how much rehab we have and what the need is. So the Global Burden of Disease study is kind of our best data available on how many people have heart disease around the world. In many countries, it's estimated through modeling. Also, they don't have incidence, they only have prevalence. So prevalence is, how many have ever had rehab, right? But what we've been assessing is how many spots patients or programs have to serve patients for a year. So there's, obviously we can't compare apples and oranges. Also, they only have ischemic heart disease prevalence, but as I showed you, there are other indications that for which cardiac rehab is recommended. And so the Global Burden of Disease study doesn't nicely capture the indications that we would be particularly interested in rehab. So this is just a rough look at, what is the burden of disease in countries, and then juxtaposing that with availability. What you would notice is that, as I mentioned, in Africa here, so blue is the least burden of disease, orange is the middle, and red is the highest burden. You might say, oh, well, there's, rehab is less likely to be available in Africa, and it's got the lowest burden, so that's a good thing. So it is technically, however, if you look at the extrapolations of disease burden coming forward, Africa is the region, the number one region, with growth in rates of mortality from CBD. It's supposed to explode. So we really need to work with Africa to get programs there. We do see also a lot of lack around the Eastern Mediterranean region, and that's the second region where growth is expected to be, in death rates is expected to be highest over the next 10 years. Here you get a sense of the total number of programs in each country. So again, this varied a lot. This again is limited because it's not juxtaposed against the actual number of patients who need it in a given year, but it does show you kind of the variability. So in the green, you have countries with more than 150 programs, yellow, more than 75, pink, more than 31, and so on and so forth. The ones in orange being just 1 to 10. And in fact, so of the 111 countries that have rehab, a third of them have only one program, and half of them have less than 5. So really, there's not a lot of capacity around the world. So we did ask about barriers to delivery. We gave them 5 common barriers that were, again, assessed in previous surveys and in the literature are stated as the key barriers. The most, so here you can see, the bars are by region at the bottom, and the most bottommost bar in each set is the global percent, or the global mean. The barriers are rated on a scale from 1, definitely on issue, to 5 being a major issue, so the higher the number, the greater the barrier. So the most strongly endorsed barrier was financial resources. That was followed by patient referral. And this one is a bit of a conundrum. Physicians should refer patients, but if there are no programs to which they can refer, then it's a bit of a problem. The next issue was human resources. And indeed, the ICCPR, as part of our knowledge translation of our consensus statement, has developed a certification program for healthcare providers in low resource settings on how to deliver each of the core components in accordance with that guideline. So this will certainly help with the human resource issue. That was followed by space and equipment barriers. Again, for quite a few of these, we see some significant variation by world region. Interestingly, my master's student is taking a look at how these differ in high versus low and middle income countries, and there's quite some interesting differences there. And there's also differences by the funding source of the program, interestingly. So whether the programs have private funding or public funding. So I mentioned about home-based programs. So we did ask the programs if they offered non-supervised delivery settings. I can tell you that the programs that offered non-supervised rehab had treated a significantly greater number of patients. So this is a means by which we can increase reach of individual programs to serve more patients, particularly if we exploit information technology. So there's been some now rehab on smartphones, and given the mobile penetrance in countries such as China and India, clearly this could have a great impact. Unfortunately, however, only 30% or a third of programs offer any unsupervised cardiac rehab, and it did not vary. We asked the programs, how could we increase your capacity? How could you deliver more home-based or more community-based cardiac rehab? Some of the main issues were kind of staff and human resources. So again, this does tie into financial issues, but we do have now at our disposal this certification program so that we can augment care capacity in these countries and expertise. Second most common was often around finance, but also for home-based, there's equipment and technology. So are we talking to patients over the phone? Does the patient have a phone at their house? Do they have a smartphone? Do they have a computer? So how are you going to make that connection? For the community-based programs, there's a lot of issues around what facilities or venues can you use. So can we exploit publicly available recreation centers, et cetera, so there is a safe place to deliver cardiac rehab? So this study has its limitations. I would say, first of all, not listed on here, is that we have to concede that our consensus guideline is a consensus guideline. So our minimum recommendations by which we've been benchmarking these programs, we don't know that those quality indicators are related to better outcomes for patients. They're just based on consensus evidence, so we do need evidence around that. So quality, how that equates to outcomes, we don't know. The second major limitation relates to generalizability. So we had a really high response rate for countries, but not for programs within countries. So that would limit generalizability. We also wonder about selection bias. So because we worked through champions or societies, it could be that the key academic centers that are more readily found were represented in the sample, and so therefore higher quality care than what is actually delivered is represented in the sample. Secondly, programs could be responding in a socially desirable way. We had the surveys were anonymous, but we did offer the respondents a summary of results if they would provide their email address. So we could tell them, this is what programs look like in your country on average compared to other countries, and to augment the response rate. And so we didn't tie that email to their responses, but this could have impacted their willingness to be truthful. So in conclusion, first of all, with regard to availability, so despite overwhelming evidence of the economic and clinical benefits, only 55% of countries had it available. And as I said, of those, most had less than 5 programs. We're now looking at kind of ranking the availability in countries in relation to IHD prevalence, but again, that's very limited because we don't have incidence data for all indications of rehab. The suggestions to scale up were around advocacy for public funding. Publicly funded, as I mentioned, we're looking into this, but publicly funded programs did offer more components and had a greater dose than programs that were funded by private sources. We need to train the cardiac rehab staff. We need to exploit community spaces in primary care to deliver it, particularly in low resource settings where there's not a lot of tertiary care centers. And really, I think exploiting information and communication technology to reach more patients is key. Finally, the nature of services is fairly consistent. So we did see some consistency around indications accepted around dose, not duration, but frequency, and also around some of the components. But there was quite a bit of variability in terms of funding source and staff composition. But again, we don't know whether, if they all had on average 5, that's great, and we don't know that one particular healthcare provider type is going to be associated with better outcomes than another. So whether that has impacted care quality, we don't know. We did show that programs that had MDs had better medication titration and risk factor management. Programs with dietitians obviously were more likely to have counseling, but we don't know for sure that the composition is related to outcomes. So just in summary, we need programs around the world to meet minimum standards, and that will promote quality, safety, and cost effectiveness in delivery around the world. So thank you very much for your attention, and there's more resources around this study, and the work of the ICCPR can be found online.
So we have lots of time for questions.
Yeah. That was great. Do you have to benchmark though the need for programs with the wealth of the country? I mean, surely sanitation is a higher priority in some countries,
Right.
and I've been in countries where you've got an annual health budget of $1, $2, or $3 or something. So how do you put this in perspective? Because campaigning for cardiac rehab may not always be a positive thing to do in some countries.
Yeah. So the question is around prioritization of needs, or what's going to impact health in countries that are low resource, right? So thank you, Jeff. So our consensus statement, we did say that it's really more related to middle income or upper middle income countries, because to your point, in low income countries, there are other needs that are more basic. But in these countries, it is really catastrophic to a family. If someone has a heart attack, they've not had preventive care, they go into the hospital, and with their heart attack, and they have to pay right there out of pocket for their care, and it's a really big issue, and it's the number one cause of death. So we would say that it is quite important. That the other issue is that they're developing cardiac units right now in most countries because this burden of disease has shifted, right, to non-communicable diseases. So we think it's an opportunity right now because they're developing these units to make sure that cardiac rehab is embedded in all of those, and that we use our best available evidence around what's cost-effective and affordable. So we've also published a review around how can we deliver all these components in the most cost-effective and affordable way, but still be clinically effective. So I think applying that so that the programs that we do implement are as cost-effective as they can be. Yes.
Great presentation, thank you.
Thank you.
So you mentioned that you need to work more with places like Africa, for example, where they don't have cardiac rehabilitation in most countries. Do you have a certain mechanism on how to achieve that, like the logistics, the communication,
Yeah.
being on the ground?
Right. So yes, the question is, that we identified that Africa is the region that really needs development of cardiac rehab. So we need to look to implementation science. We have partners in South Africa and the Africa Heart Network that we work with around how to do this. A lot of the programs there are NCD rehab programs, so they are cancer, lung disease, all in one. And so I think we would, need to work with them on those models. And I think we need to look at what has worked in terms of delivery and reaching patients in maybe HIV or other communicable diseases, and how that's been, and kind of work that way. But the resources and the disparities are vast, and we recognize it's a major issue. And so ICCPR really tries to support our partners in Africa and work with them to promote this. And we have an advocacy toolkit as well. So we've looked at we've surveyed countries around the world, looking at who funds, and listen to the members about what do they need to advocate. And we have some success stories. So in Iran, for example, they were able to advocate, and now the Ministry of Health has a policy that rehab is funded. And you should see the number of programs there. And the EMR, it's unsurpassed to any country, and the growth in the number of programs has been just in the last 5 years. So, China too. China, they had a policy change. They actually have 200 programs there, which is the same as Canada. But still, this is a lot. They used to have 5. So I think that there is some success and some settings, and we need to learn from those and implement in other places. Yeah.
Thank you, that was great. I'm just curious, is there any data on compliance with cardiac programs, whether that varies by region? Or
Sure.
what happens?
Yeah, so the question was about compliance with cardiac rehab itself. So this is an excellent question. So I'm just talking about the health system and having spots for patients to come into. So we've done a meta-analysis on this, and we find adherence is about 66%. So patients adhere to 66% of prescribed sessions on average, which is 2/3. There's often numbers floating around in literature that I don't think are evidence-based that say about 50%. So, we were looking at rigorous quality studies, so, it could be that our rates are elevated. We don't know exactly, but I would say that it is an issue that there is insufficient adherence because patients aren't going to accrue the benefits of 20% less mortality if they don't go. We know more cardiac rehab is better, so the dose is very important. So right now we're updating the Cochrane review on interventions to increase uptake. So there are a few strategies that are known to work and get patients in and keep them there. But we've been able to be the first to do a meta-analysis on this, and this will be coming out in the next couple months. So we'll have actual strategies to keep them in once we get them there. Yeah.
Did you ask them about the proportion of women attending cardiac rehab programs?
Right, so the question was whether we asked about the proportion of women attending the programs. So another very important point is that there is inequity. So very few people get into rehab, but once they do get in, we don't see some of the patients who are most vulnerable and need it most. So there is really good data that women might actually have better mortality benefits than men if they go, but they're significantly less likely to be represented in programs. Same with for rural patients, low socioeconomic status patients, and ethnic minorities. We did ask them in a previous survey, but not this one, but we did ask about women-only programs, and whether they offered that, so something to kind of engage more women. And this was kind of most common in the Eastern Mediterranean region, and this would be just due to religious reasons. But that, yeah, that's all that we know about that. Yeah.
Have you ever thought about discerning areas of conflict from the rest of the world? Like-
Areas of conflict.
Yeah, like
right.
Syria and
So
stuff.
yes, right. So this is a good point. So when we did our pilot study to this, we administered the survey in countries where of the world that are considered Arab, and we did kind of look at the variation in is there conflict and how does it impact infrastructure, and the issue is there's so much variation in terms of how the healthcare systems are set up, the amount of violence, and so we're looking at the Human Development Index too, kind of in relation to all the countries, but we found that there's only 8 countries around there that even had any, and they had 1 or 2 programs, so it's just still so nascent in that part of the world, but clearly that would impact the care organization, and yeah.
You didn't mention politics as one of the barriers, but to me that varies widely. I mean, we have national policies here, the national healthcare in Britain. In the States, it's patchwork. Even in developed countries, I would think delivery, if you have national standards, but healthcare is delivered on a provincial level, how do you put those together?
So it's a question about policies supporting rehab and also kind of countries. So with Paul O, who's the head of our cardiorespiratory fitness team, we're writing up the data from Canada. And so it's true that in Canada, each province has its own policy for rehab reimbursement. So it's really interesting because in Ontario, it's covered, through the ministry here at Rehab or through hospital global budgets. So we have maybe 70 programs here in Ontario. Quebec next door, it's not. It's covered by WSIB if someone happens to be working and not retired, and they have about 3 programs for the entire province. So, but it's never been established who funds, and if you ask the Canadian Association of Cardiac Rehab, they don't know the funding policies in every province. They haven't collated that, so we've been now the first to put that together. And again, we think that we can leverage that to look at where is it offered more commonly, and then how can we use what's working and apply it in places where it's not.
Do you not need some national umbrella, though, that says these are the minimum standards that should be applied regardless of who the delivery is? How do you do that?
I guess as our association, the Canadian Association of Cardiac Rehab, certainly lobbies to have it, that there be a policy that, every patient access cardiac rehab, but there are competing priorities, as, mentioned, so that makes it difficult, but as we mentioned, in Iran, for example, they didn't have a policy. They got one through lobbying, and then they were able to increase the number of programs that they have. So, yeah.
So basically, you have all this information right now, and I want to ask, how does a group like this contribute to the solution?
Sorry, how does a group like this contribute to the solution? Okay, that's a good question. Yeah. So it is one of these wicked problems, I guess. There's multiple factors at play, and it's quite complex. And so I guess I would say, we go to our website, we have an advocacy toolkit, which looks at, kind of 5-pronged approach to what messaging we're going to have, bringing the evidence that we have to, various stakeholders, looking at the different stakeholders, how do we engage with those stakeholders. So I think it's a real need for concerted advocacy, and here in Canada, our association is really, I would say it's under pressure right now because there's very few financial resources there, and so they're kind of trying to survive more than being able to be active and advocating. But we hope when we write up our Canadian data and we look at this that we could engage with them around what could be the implications, et cetera. I also work with the Canadian Cardiovascular Society, and they have a whole quality initiative under Paul Dorian. He's a physician at St. Mike's, a cardiologist. And so through that, we are really trying to look at the minimums across Canada in our programs and what's the quality of our program. So we've developed, I was the lead, and we developed quality indicators for Canada. And so, we've mapped now. This is where we do well, this is where we don't do so well. Let's look at this by province, et cetera. So we do have data to support our messages, but it's a matter of reaching the right people and effecting change. Yes.
Is it ever possible that you might discourage the spread of rehab by making it seem too difficult to achieve, and that maybe just talking about simple exercise program or dietary control might be less intimidating for places?
Right. So the question is whether we should be less intimidating about, what minimum standards that we suggest. And so I agree with you fully. And so we talk in our consensus statement about programs just implementing what is feasible and what they can do. We say, kind of this is the bare bones to get there. And if you can't offer more, you can't. But it's true. We just want to get everybody active. We just want you walking around your community. You don't need a stress test. You don't need an exercise prescription necessarily. Let's get you the minimums, and whatever you can get, let's give that. And that's the message that comes through, because it's true in many of these places, it's just not feasible. Yeah.
Actually, following on this point, part of the solution might be designing equipment and solutions that are financially accessible in those areas. So they might not have the capability of designing the solution themselves or the equipment,
Right.
but they might be able to make it if it is designed for them.
For them,
And
yes.
there's a trend towards that as well.
Right. Yeah. So.
Frugal innovation sort of.
Right, yeah, so I'm working with some groups in the UK, and we are adapting, so there's a group in Australia that's developed a smartphone-based rehab, and so we're working now, we've got a grant into this MRC group out of the UK with a global call to adapt it for Malaysia and Bangladesh, and see what kind of uses they can have and how we can adapt it to work there. And Gabriella Gizi from our group is another expert kind of in cross-cultural adaptation and translation of tools so that they work in different countries. So we're down in Brazil, and we're implementing comprehensive rehab for the first time. So in Brazil, rehab is only exercise. So we're now looking at, hey, does patient education, can we put it in? Is it feasible? Do patients like it? Can the staff accommodate it? So we're out there kind of testing in different places, and this is the trajectory that we study.
Okay, so thank you, Sherry, that was a great talk, and thank you, everybody, and we'll see you at the next round.